Interpretation of Acid-Base Disorder Part 3. Dr. Jalal Mohsin Uddin. MBBS, DTCD, FCPS Pulmonology. The points which will be discussed here. 1. Metabolic acidosis, Slide 3. 2. Winter's equation, Slide 8. 3. Anion Gap, Slide 10. 4. Type of metabolic acidosis, Slide 18. 5. Serum lactate, Slide 24. 6. Metabolic alkalosis, Slide 26. 7. Summers equation, Slide 31. 8. Base excess, Slide 32. 9. Clues for mixed disorder, Slide 33. 10. Delta anion gap, Slide 35. 11. Relation of serum electrolytes with underlying acid-base disorder, Slide 39. 12. Possible flowchart for ABG report interpretation, Slide 40. Metabolic acidosis begins with fall in serum HCO3 due to accumulation of non-volatile acids. In metabolic acidosis, pH less than 7.35, both HCO3 less than 22 milliequivalent, L, and PCO2 less than 40 mg decrease. Mechanisms of development of metabolic acidosis. 1. Excess acid production that overwhelms renal capacity for excretion. Example, diabetic ketoacidosis. 2. Loss of alkali. Leaves unneutralized acid behind. Example, diarrhea. 3. Renal excretory failure. Normal total acid production in face of poor renal function. Example, chronic renal failure of any cause. Symptoms of metabolic acidosis. Symptoms are not specific, and diagnosis can be difficult unless patients present with clear indications for arterial blood gas sampling. Symptoms may include palpitations, headache, altered mental status such as severe anxiety due to hypoxia, decreased visual acuity, nausea, vomiting, abdominal pain, altered appetite and weight gain, muscle weakness, bone pain, and joint pain. People with acute metabolic acidosis may exhibit deep, rapid breathing called Kushmal respirations, which is classically associated with diabetic ketoacidosis. Extreme acidemia can also lead to neurological and cardiac complications. Neurological: lethargy, stupor, coma, seizures. Cardiac: abnormal heart rhythms, for example, ventricular tachycardia, may lead to low blood pressure. Physical examination can occasionally reveal signs of the disease, but is often otherwise normal. Compensatory changes in metabolic acidosis. Tissue and red blood cells act to increase serum HCO3 by exchanging intracellular and K for extracellular H+. Try to raise serum HCO3. Increased pulmonary ventilation. Fall in PCO2 brings pH back toward normal. Winter's equation in metabolic acidosis. In metabolic acidosis, Winter's equation is applied to see whether the change of PCO2 is due to compensatory process or due to associated respiratory acidosis or alkalosis. Formula 7 PCO2 equals 1.5 multiply HCO3 plus 8 plus minus 2. Easy to remember the compensatory PCO2 in metabolic acidosis. PCO2 equals last two digit of pH. Winter's equation. Continue. If PCO2 level within the range of equation, it indicates the fall of PCO2 is due to compensatory process. If more than that, it indicates associated respiratory acidosis. If less than that, it means there is associated respiratory alkalosis. Understanding of anion gap, AG. We know total anion equals total cation in blood. Total anion include chloride plus bicarbonate plus unmeasured anion, UA. Total cation include sodium plus unmeasured cation, UC. If the unmeasured anion in a person exceed the unmeasured cation, then the difference is called anion gap, a G. Cl- plus HCO3 plus UA equals Na plus UC. Formula 8 Cl- plus HCO3 plus UA equals Na plus UC. If U are greater than UC, so U minus UC equals Na plus Cl plus HCO3 So Ag equals Na plus Cl plus HCO3 The anion gap can be estimated by subtracting the sum of the chloride and bicarbonate concentration from the sodium concentration. Anion gap. The normal value of Ag is 12 milliequivalent L, but sometimes it is considered up to 16 milliequivalent L, if potassium is considered in calculation. In case of concurrent metabolic acidosis and alkalosis, the pH can be normalized, also the HCO3, but not the anion gap. It will be definitely increased. Hypoalbuminemia can cause low anion gap. Type of metabolic acidosis. 1. High anion gap metabolic acidosis. A. With normal plasma osmolality. B. With increased plasma osmolality. 2. Normal anion gap metabolic acidosis. A. Hypokalemic forms. B. Normokalemic or hyperkalemic forms. 1.A. High anion gap acidosis with normal plasma osmolality can be found in following conditions. Uremia due to renal disease. Lactic acidosis, serum lactate level more than 7 millimoles per liter. Ketotic, diabetic ketoacidosis. Salicylate intoxication, serum salicylate more than 30 mg/dl. Normal human reference range of osmolality in plasma is about 275–299 milliosmoles per kilogram. 1.B. High anion gap acidosis with increased osmolality can be divided into two groups. Normal pH in following conditions: A. Increase acetone level, B. Increase ethanol level in blood. Decreased blood pH in following conditions: A. Methanol poisoning, B. Ethylene glycol intoxication. 2.A. Normal anion gap hypokalemic metabolic acidosis can be found in following conditions. Loss of intestinal fluid is found in following conditions, example, A. Diarrhea, B. Vomiting, C. Ileostomy, D. Fistulae. Post-hypocapnia. Use of carbonic anhydrase inhibitor, example, acetazolamide. Urethral diversions, example, ureterosigmoidostomy. 2.B. Normal anion gap normokalemic or hyperkalemic metabolic acidosis. Early renal failure. Obstructive uropathy. Acid ingestion. Sulfur toxicity. Type of renal tubular acidosis. Hyperchloremic metabolic acidosis. Hyperchloremic acidosis is a form of metabolic acidosis associated with a normal anion gap, a decrease in plasma bicarbonate concentration, and an increase in plasma chloride concentration. Although plasma anion gap is normal, this condition is often associated with an increased urine anion gap, due to the kidney's inability to secrete ammonia. Causes of hyperchloremic metabolic acidosis. I. Hypokalemic. Proximal renal tubular acidosis drug-induced, acetazolamide. Distal renal tubular acidosis. Post-hypocapnia. Diarrhea. Pancreatic fistula, biliary drainage. Correction phase of diabetic ketoacidosis. 2. Hyperkalemic, normokalemic. Type 4 renal tubular acidosis, interstitial nephritis. Hypoaldosteronism. Hydronephrosis. Dilutional acidosis. Approach to a patient of hyperchloremic metabolic acidosis. Urine anion gap can be utilized whether the cause of hyperchloremic metabolic acidosis is due to a renal tubular defect or due to other causes such as diarrhea. The urine anion gap is calculated as follows. Urine Na plus urine K, minus urine Cl. A negative urine anion gap, if Cl greater than Na plus K, indicate gastrointestinal LAS like diarrhea, vomiting. A positive urine anion gap, if Cl less than Na plus K, indicate renal tubular acidosis. Approach to a patient of hyperchloremic metabolic acidosis, continue. Type of renal tubular acidosis can be separated by measuring urine pH and serum potassium, K, level. If urine pH greater than 5.3 indicate renal tubular acidosis type, L. If a pH urine less than 5.3 plus low serum K indicate renal tubular acidosis type, LL. If a pH urine less than 5.3 plus high serum K indicate renal tubular acidosis type, L. High anion gap metabolic acidosis can exist with minimal elevation of anion gap in these conditions. Hypoalbuminemia, hypergammaglobulinemia, polyclonal, monoclonal. Severe hyponatremia, greater than 170 millimoles per liter. Hypercalcemia, 1 milliequivalent rise causing 1 milliequivalent fall in anion gap. Hypermanzemia. Diarrhea. Vomiting. Distal renal tubular acidosis, RTA, type L. Algorithm. OG equals osmol gap. Footnote, serum lactate. A serum lactate level measures the amount of lactic acid in the blood and is a fairly sensitive and reliable indicator of tissue hypoperfusion and hypoxia. Any disorder that causes an imbalance between lactate production and clearance can lead to lactic acidosis. Serum lactate level of 2 millimoles per liter, 18.2 mg/dl, is normal value. A serum lactate level greater than 2 millimoles/L may be a new emerging vital sign of septic shock. Metabolic alkalosis. The hallmark of metabolic alkalosis is a rise in the serum HCO3. In metabolic alkalosis, pH 7.45, both HCO3, 29 milliequivalent, L, and PCO2, 40 mm of Hg, increase. Compensatory change. PCO2 increase due to compensatory hypoventilation. But this compensatory response is much lower than that of compensatory hyperventilation associated with metabolic acidosis. PCO2 rarely goes higher than 45 mm of Hg, maybe up to 25% of cases, and it is unusual to go beyond 55 of Hg unless superimposed respiratory acidosis is present. Tissues and RBC also act to lower serum HCO3 by exchanging intracellular H+ for extracellular K and now result lowering of both serum HCO3 and K. Symptoms of metabolic alkalosis. Mild cases of metabolic alkalosis often causes no symptoms. Typical manifestations of moderate to severe metabolic alkalosis include abnormal sensations, neuromuscular irritability, tetany, abnormal heart rhythms, usually due to accompanying electrolyte abnormalities such as low levels of potassium in the blood, coma, seizures, and temporary waxing and waning confusion. Causes of metabolic alkalosis. The most common causes are volume depletion, particularly when involving loss of gastric acid and chloride, Cl, due to recurrent vomiting or nasogastric suction, and diuretic use. The causes of metabolic alkalosis can be classified into two groups according to the urinary chloride concentration. Causes of metabolic alkalosis. Continue. Urinary chloride less than 20 milliequivalent, L. vomiting, nasogastric suction, chloride wasting diarrhea, colonic callus diarrhea, diuretic therapy, post-hypercapnia, urinary chloride greater than 30 milliequivalent, L, primary hyperaldosteronism, Cushing's syndrome due to adrenal, pituitary and ectopic exogenous steroid, glucocorticoid, adrenal gland, 11 or 17 hydroylase defects, K and Mg deficiency, milk alkali syndrome, hypercalcemia with secondary hyperparathyroidism, Summers equation in metabolic alkalosis. Summers equation is applied to see whether the change of PCO2 is due to compensatory process or due to associated respiratory acidosis or alkalosis. Formula: 9 PCO2 equals 0.9 multiply HCO3 plus 9 plus minus 2. Basic cess. Clues for the presence of mixed disorder. With the sole exception of chronic respiratory alkalosis, a normal pH value in the setting of an abnormal PCO2 and bicarbonate concentration signifies a mixed disturbance. Compensation rarely corrects the pH to normal. The more severe the primary disorder, the less effective is the compensatory mechanism at returning the pH to normal. 2. Direction of PCO2 and HCO3. The PCO2 and serum HCO3 concentration always deviate in the same directions. If PCO2 and HCO3 deviate in opposite direction, then there should be mixed disorder. 3. pH change in the opposite direction. A pH change in the opposite direction to that predicted for a known primary disorder signifies a mixed disturbance. 4. The lack of compensation in an appropriate interval defines the presence of a second primary disorder. Delta anion gap. The normal anion gap is approximately 12. In an uncomplicated high anion gap acidosis, for every 1 millimole/L rise in the anion gap, there should be a concomitant fall of 1 millimole/L in the bicarbonate, HCO3, concentration. The difference between the patient's anion gap and a normal anion gap is called delta anion gap, delta Ag. The delta Ag and delta HCO3 are calculated by the following formulas. Delta Ag equals patient's Ag, upper normal Ag. Delta HCO3 equals lower normal HCO3, patient's HCO3. Example: nate a patient with an anion gap of 20. So, his or her delta Ag equals 8. If delta HCO3 is greater than delta anion, that is, delta HCO3 greater than delta Ag, following things may happen. Mixed high anion gap acidosis plus normal anion gap acidosis. Most commonly, mixed high anion gap acidosis plus chronic respiratory alkalosis with a compensating hyperchloremic acidosis. If delta anion gap is more than delta bicarbonates, that is, delta Ag delta HCO3, then it will be a case of mixed high anion gap acidosis plus primary metabolic alkalosis. Relation of serum electrolytes with underlying acid-base disorder. The chloride and potassium concentration can also provide clues to the underlying acid-base disorder. If the chloride concentration changes in proportion to sodium, it reflects a change in hydration. If chloride changes in excess of serum sodium, the hyperchloremia suggests alkalosis. Similarly, hyperchloremia suggests an acidosis. Hyperkalemia is associated with acidosis and hypokalemia is usually associated with alkalosis. Possible flowchart for ABG report interpretation. Possible flowchart for ABG report interpretation. Continue. All the normal values. pH 7.35 to 7.45. H+. Concentration 40 nmol/L. expected level of PCO2, 35 to 45 mm of Hg. Minimum expected PO2, 60 mm of Hg. SpO2, 95 to 100%. HCO3, 22 to 29 milliequivalent, L. Normal anion gap, 12, 16 in some articles. Basic S, 2 to plus 2 milliequivalent, L. Serum lactate level of 2 millimoles per liter. 1 kilopascal, equals 7.50 millimeters of Hg. All the formulae. Formula 1. If PO2 plus CO2 greater than 140, it indicates patient is on supplemental O2 or it is a lab error. Formula 2. If PO2 plus CO2 140, it indicates patient with or without supplemental O2 or it is normal or pathological. Formula 3. Minimal expected PO2 equals 80, age, 60. Formula 4. H plus equals 24 multiply PCO2, represent lung activity, divide by HCO3, represent renal activity. All the formulae. Continue. Formula 5, change in H plus, divide by change in PCO2, equals 0.8. For acute respiratory acidosis or alkalosis. Formula 6. Change in H plus divide by change in CO2 equals 0.3. For chronic respiratory acidosis and alkalosis. All the formulae. Continue. Formula 7. PCO2 equals 1.5 multiply HCO3 plus 8 plus minus 2 Winter's equation to see the respiratory compensation in metabolic acidosis. Formula 8. Cl plus HCO3 plus UA equals Na plus UC. Formula 9. PCO2 equals 0.9 multiply HCO3 plus 9 plus minus 2. Summers equation to see respiratory compensation in metabolic alkalosis. Thank you all. End of part -3.